Barbara Kayahan unfortunately passed away. So we are going to tell him our sympathy. Professor Kayahan, please accept our sympathy for your loss. I know during the last year, you did a lot for your mother, and I believe this fact and helping your mother in the last days of her life was very, very important for you. And I believe she's going to heaven with a lot of good memory from her family. Please accept our sympathy.
Thank you, brother. Thank you very much. Thank you to all. Unfortunately, I lost my mother at the beginning of March. There's nothing to say. I know this is life, but day by day, I can. That's all. That's all. Unfortunately, nothing to say. Nothing to say. I am missing her. I am missing the only thing that I can say is I am missing her every day, of course. Yeah. Thank you. Thank you.
Yep. Yeah, but the good thing, Barbara, is you should know that you are not alone. We are all with you in this situation.
Yeah, I know.
Okay, I know. With your permission and the permission of Professor Ibrahim Abu Tahun, the head and the chair of the educational committee of the Asian Pacific Endodontic Confederation, I'm going to start the 4th Asian Pacific Endodontic Confederation APEC online journal club, which is run by Tehran University of Medical Sciences according to the agreement we signed with the president and the chair of the educational committee. So today we have Professor Emmanuel Silva with us. He publishes more than 50 articles. You can see his face looks very young. However, behind this very young face, there is a very, very smart brain who published a lot of articles in the field of endodontology. I know him from my cooperation with International Endodontic Journal, and as one of the member of the editorial board, I have received a lot of articles from him, and I know him very well based on his very smart publication. Recently, he and his colleagues, including Professor Paul Lummer, who is the chief editor of the Endodontic Journal, International Endodontic Journal, they published a very, very attractive article about the conservative access cavity preparation and some sort of criticism about the previous articles. And some of those articles that previously published actually published by Silva himself. So Emmanuel is one of the person who involves in actually the suggestion of this new approach for access cavity preparation. And also he himself tried to classify it, to give us a new system of how we can communicate with each other by using the new terminology. So Arvin is going to discuss that and give us his presentation and some sort of appraisal of, Armin, please wait at the moment, please don't share. Let us start officially and then please go ahead and share. Arvin, please unshare your screen. Thank you. So therefore, the article that we are going to discuss is the article that I already mentioned. And if you look at the name of the authors of this article, you will see a lot of famous names, including Professor Gustav Derus. So he's actually is one of the famous endodontists in the world and Brazil also. And as I said, Professor Versiani from Italy and a lot of people in that article that I'm sure Arvin and Emmanuel are going to speak about them as well. So Professor Ibrahim Tahun, the Dean of the Educational Committee of Asian Pacific Endodontic Confederation, I ask you to officially start our 4th online journal club. Please go ahead.
Thank you very much, Brother Mohammed. Thank you for the introduction and thank you for introducing me. First of all, I want to start by congratulating you and all my dear colleagues in Iran for the Nowruz celebrations, which start and they mark the beginning of the new Iranian year and also the spring. And we hope that the beginning of the spring will be a beginning of pleasure and safety for all the humanity after the disaster of COVID-19. As you see, we every day unfortunately lose relatives, friends, and colleagues. Hope everything will be fine. I want also to take this opportunity to welcome the president of APEC, Dr. Mehmet Bayburakayhan, who always honors us with his presence. And then I want to, from him, I want to welcome Dr. Silva. We are really pleased to have him with us. This topic is one of the most, there's a great discussion about the topic of access cavity and endodontics. And it's good to exchange now opinions and ideas about this thing. So thank you very much. And I want to thank you on behalf of APEC, Dr. Professor Mohammed, for this cooperation with the Tehran University of Medical Sciences. We are doing very well and hope this will continue in the future. Thank you very much. And thank you all. Thank you, Dr. Virish, also for being with us. Dr. Rizai, who will be the coordinator of this session. I want to thank them all and not to waste the time of this webinar. Thank you all. Thank you very much.
Thank you very much, Professor Abu. It is very important also to mention the very important role of Professor Özgür İlke. She is the secretary of the educational committee. She did a great job by sending the information about this online journal club to all of the colleagues around the world. Thank you very much, Professor İlke, for your help and your cooperation. So,
it's a great pleasure for me.
Thank you very much.
I don't see her. I don't see her.
I think you need to change your view to the view. You can see all of us. You can see all of us now.
Yeah, now it's okay.
Okay. Yeah. Professor Abu Taun, thank you very much by mentioning the Iranian New Year, which is a start on 21st of March, which is the first day of spring. And I'm very happy to say that this is actually an international day that they called it Nowruz, which is in Persian means new day. And in reality, it is new year. And we in Iran and in many countries, we celebrate actually this. And I'm in holiday actually at the moment. So I'm not in the capital, I'm in countryside enjoying from the nice spring here. So I asked my colleague to give you a very short video about the history of Nowruz, which is 2 minutes video clip, maybe good and informative. Mrs. Sadeghi, please go ahead. Zohre, please go ahead and share the video clips, please. While Zohre is trying to share the information about the Persian New Year with you, Persian New Year is actually the first day of spring, which is the day that we believe the duration of the day and night are almost equal. So I think this is now starting.
Is the name of the Iranian New Year's Day, also known as the Persian New Year, which is celebrated worldwide by various ethno-linguistic groups. Nowruz is the first day of Farvardin, which is the first month of the Iranian solar calendar. The word Nowruz is a combination of Persian words no and ruz, meaning new day, and it has been celebrated for over 3,000 years. Nowruz usually occurs on March 21st or the previous or the following day, depending on where it is observed. The moment the sun crosses the celestial equator and equalizes night and day is calculated exactly every year, and families gather together to observe the rituals. There are several holiday customs during Nowruz festive period, such as house cleaning before the new year, visiting family and friends during the 13 days, decorating the house, and of course, the most symbolic tradition is the Haftzin table. Haftzin is the name of the special table of Nowruz, the festival of New Year and the beginning of spring. This table is made up of 7 items that start with the letter S. In fact, Haftzin literally means 7 S letters, and every item symbolizes something positive for the coming year. Sumac, which are crushed spice of berries, symbolize the sunrise and the spice of life. Senjed, which are sweet dry fruit of the lotus tree, symbolize love and affection. Serke, which is vinegar, symbolizes patience and age. Sib are apples, and these symbolize health and beauty. Sir is garlic, which symbolizes good health. Samanu, which is wheat pudding, symbolizes fertility and the sweetness of life. Sabze, which is sprouted wheatgrass, symbolizes rebirth and the renewal of nature. Apart from these 7 items, there are other things placed on the table that depend on the family traditions. The table is usually set some hours before the beginning of the new year. Then the family members spend the last moments of the ending year sitting together and reading their holy book or poems of Hafez and Ferdowsi. However, don't just stop there with celebrating this joyous festive time. Let's experience more of Nowruz together.
Thank you very much, guys. So now it is time for Arvin to start his presentation. Welcome, Professor Talal from Syria and all of our colleagues from around the world. Thank you very much. Arvin, please go ahead.
In the name of God, my name is Arvin Rezai, a postgraduate student of Tehran University of Medical Science, and I'm very honored to present this presentation today. Today, we are going to discuss with each other about current status on minimal access cavity preparation, a critical analysis, and a proposal for a universal nomenclature. So we know that today we are going to discuss about 2 things. First of all, we are going to came to a unique nomenclature to use the united words for different kinds of access cavity, and beside that to see what's the effect of different types of access cavity on our RCT's result. First of all, we are going to discuss briefly about pros and cons of minimal invasive access cavity preparations. Yes, we know it's very useful to preserve the fracture resistance of our tooth after the teeth being root canal treated. But beside that, we know that it may compromise our procedures, our RCT procedures. For example, it may complicate finding the exact location of orifice canals, and also other procedures such as cleaning, shaping, and filling the teeth, and so it would be more difficult for us. And also, as a result, it may increase the iatrogenic complication of that. For example, missed canals, deviations, and the fractures of our instruments inside the tooth. So as we know, we don't have enough and sufficient evidences around these types of access cavity preparations, and we see these types of access cavities mostly in social media as an advertisement, as another show off things, and scientifically we don't have enough and sufficient evidences to introduce these types of access cavity preparation in our routine clinical practice, or base our undergraduate and postgraduate students education based on these access cavities. So we are now continuing to teach the other previous traditional access cavities to our students. So the aim of this study is to, first of all, review the available literatures on minimally access cavity preparations, on root canal treatment, and also retreatments, both procedures. And after that, to introduce to come to a unique and united nomenclature based on the different abbreviations that we have, to united all of them, and at last to find the areas that we need more research to conduct. At the review of the literature, finally, after excluding a lot of papers, 28 papers have been found that their topic was around these 4 headlines, that various types of minimal invasive access cavity preparations were discussed in these papers. And also they were, more importantly, they were comparing the fracture resistance of the teeth after or before to compare different types of access cavities on these effect on these fracture resistance of the tooth and stress distribution in the tooth after preparation of the tooth. And beside that, beside the effect of on the fracture resistance, the second one, their effect on the different stages of our procedure in root canal treatment and also retreatments. So before going to, I want to first mention the deep nomenclature also in posterior and anterior teeth. But before I go forward, is there any questions? Yes.
Arvin, please go back to the previous slide. I have a question from Emmanuel about that.
This slide?
Looking at this, yes, please. Emmanuel, looking at this slide, which actually extracted and adopted from the article itself, we can see that somehow the article tried to emphasize on these 4 important things, including the stress distributions and the influence on different stages of root canal treatment. What was worried us more than others is about the efficacy of this type of access cavity, and is it enough for us to clean the root canal system by entering a very small access like that, whatever it is? I'm not speaking about a very special type. I'm speaking about all types of this minimally invasive access cavity preparation. I cannot see that one here. I mean, the effect on the cleaning itself, the effect of removal of bacteria from root canal system. What do you think about that?
That's a good question. And in fact, we included such type of evaluations in the last sentence, the influence on the different stages of root canal treatment. We have included the studies that evaluated microbial reduction, the cleaning ability, and other issues. So it was included. We have a specific topic of this. So
the last sentence, which is their influence on different stage of root canal treatments, now it means that it includes a lot of things. It's not just cleaning and shaping. It is about the obturation, the quality of obturation, obviously, and of the stage of root canal system in general. Thank you very much.
Yes.
Is there anything else that you want to add to this part of introduction before Arvin is going to the next part?
No, I'm thinking it's okay right now. Just one thing is that the rationale to perform the access cavity initially was based on the fracture resistance of a tooth. But the first studies, the Clark and Kademi studies, did not evaluate this fracture resistance. It was merely a case report study, and lots of people use this reference as a gold standard reference, but I cannot agree with that use.
Yeah, that's very important, because Obviously, if we can make it larger, we can clean easier. But the thing is, we want to keep it small because we want to keep it stronger. That is the case. So if we are not going to look at the strength of the tooth after access cavity preparation, what is the point to look at that like this? Thank you very much. That's a good point. Okay, Arvin, go ahead. Is there any other questions from anybody? Please just raise your hand and then turn on your microphone and ask it from Emmanuel. Okay, it's clear now. Arvin, go ahead.
Thanks a lot. In the continue, we are going to discuss about the nomenclature of different access cavities. So we start with posterior teeth, and at first we discuss about traditional access cavities. As we all know, in these access cavities, we completely remove the pulp chamber roof, and we make our axial walls diverted to the occlusal. And as we see in this picture, it's the picture of a traditional or conventional access cavity. The next one is conservative access cavity that we are going to discuss about it. It's same as traditional, but here comparing to this, there is one difference. It's the axial walls are smoothly convergent instead of divergent, but also this type of access cavity can be performed with divergent wall, but its name is different. You see at the end of the conservative access cavity, we have divergent wall, and the shape of these two access cavities are a little bit different. Generally, they are conservative, but the walls are different. In the left one, it's convergent. The right one is divergent. The next one is ultra-conservative access cavity that is also called ninja access. This type of access cavity is more conservative than the previous one. And as you see, it's same as conservative, but here we don't have extension that we had in the previous access cavity, and it's as we see in this picture, very small, very less extension, and just the entry of our burr, and very little extension to the orifices. And the other type of access cavity is truss access cavity, that here we aim to preserve our dentinal bridge, and we just enter to find orifices, and we just want to see the location of the orifices. And this is the shape of this type of access cavity. We see we have two separate cavities, and the remaining bridge is untouched, and we don't remove it to help the fracture resistance of the tooth to increase. Maybe the aim of this is that. The next type of access cavity is caries driven. It's very simple. We just remove caries. We don't touch the remaining tooth structures. Here is mentioned, including the soffit structure. If I want to add a brief explanation about soffit, the word soffit, it's a basically architectural word. It refers to the foundation, the structures that are mostly horizontal and make the most resistance and strength of the structure. That here in our topic, it's about teeth, and maybe it's remain here. It mentions to the roof of the to the pulp chamber and other walls that helps to maintain this strength of the tooth. This is the shape of caries driven access cavity. We just remove caries, and we do not touch the sound areas of the tooth. The last one is restorative driven access cavity. Here we just remove existing restorations, and we do not touch the other part of the remaining sound tooth, and they are remained untouched as it's seen in this picture. We just remove the maybe composite or amalgam that were exists there, and we do not remove this remaining of sound tooth. These were all about posterior teeth. Briefly, I showed the meaning of this access cavity in anterior teeth. As we know, the traditional one, we just remove pulpos, lingual shoulders, and extend this access to the incisal edge. This was traditional access cavity in anterior teeth. Again, the conservative is same as before. It's very similar to traditional, but less extension in any direction. Here we conserve pulp horns, and we aim to preserve our dentines that are that there is no need to remove them in this access cavity. And it's the shape of this kind of access cavities in anterior teeth compared with the previous one. We see the extension is less and no other variation here. And also the pulpos are
can I stop you here,
yes,
please?
Yes, yes, of course, you?
Yes.
Yes.
Emmanuel, I'm worried now about the discoloration of the tooth in anterior teeth, because speaking about the posterior, I'm not worried about the discoloration, obviously, but in anterior, one of the very big challenge that we have is about the discoloration. What do you think about that? Is it should be a part of the outcome that we need to look at that during the studies or not? Or can you give us some description about that? And I'm going to ask also Professor Talal, because I've seen a lot of access cavity that Talal showed us in his very fantastic presentation, that he used different types of these conservative access cavities. Emmanuel, and also another question, which is the second question after discoloration, is about the caries-driven access cavity. Because speaking about the caries, we don't know where is the location of the caries. So if we have, for example, a class 5 caries, then do we have enough access to the root canal system, or the apical 1/3 of the canal, or not? Please, Emmanuel.
Perfect. First of all, regarding the problem of discoloration, I completely agree with you, and it's a big issue. And in fact, there are some studies. I remember the Marquesan et al. Study that demonstrate that conservative access cavity has major problems with the coloration, and so I think it's a big issue, and further studies are needed. And regarding the caries-driven, yes, it's also a problem, especially because in the social media, we've seen a lot of case reports of cases that people do the access cavity through the caries, but a lot of times without removing completely the carie. So it doesn't make any sense to me, because you have a bad structure, and also you have a contaminated structure, and it seems to not be in accordance with the technical and biological endodontics procedures.
Emmanuel, I'm very happy, because I was worried when I invited you. I was very worried that you are going to tell us about a very small access cavity. But now I can see that you are very, very realistic about this issue, because I was very worried about that, to be honest with you. And Professor Aboutoun always criticized me to be very harsh with the authors. But this time I'm very happy that you are one of the authors, that you don't defend actually this type of access cavity.
In fact, if I can talk a little bit, I think the traditional access cavity, and if you go to books from the beginning of the century, of the last century, always the description of the traditional access cavity was to save as much as tooth as possible. Every book says the same thing. And what I believe is that nowadays, with the modern equipments that we have, we can do a traditional access cavity smaller, but following the principles of endodontics. For example, removing all the roof of the pulp chamber. I cannot agree with with performing an access cavity and you leave the roof of the pulp chamber, because I think you have a lot of problems when you do not remove the roof. So I have a lot of case that I performed with the traditional access cavity, which nowadays I call them the contemporary access cavity, that is traditional, but with the technology that we have today, without removing too much structure, but following the endodontic principles. So this is
that's great. That's great.
A resume of what I believe that is possible today. But we
Thank
will
you very much.
further.
Yeah, we will discuss. So I'm going to ask Professor Nahlawi. Talal, please go ahead and give us your idea about these various types of access cavities, and also about this good classification that Emmanuel and his co-workers actually suggested for endodontology, because it's now easier for us to communicate with each other, speaking about different types of small access cavities. Talal, please.
Thank you very much, my friend. First of all, let me adore your selection actually of the articles, because I'm following this journal club for since it started, and really I'm proud of your selection. Also regards to Dr. Emmanuel for this very nice article. I would like to emphasize the fourth point from the start about the access cavity and its influence on the root canal treatment stages. Actually, I will give an example for a case that was referred to my clinic, and it was for anterior teeth, and the patient was the son of the dentist, and he tried to make an access cavity, an ultra conservative access cavity just from the palatal, and he referred the case for me because he keep doing irrigation and doing calcium hydroxide dressing, and still the sinus tract didn't disappear, and a lot of pus coming out. And when I look for the access cavity, I told him, how come you will be able to be sure that you are flushing the debris? It's very, very, very small. Once it was corrected, a huge amount of debris get out, and the case was solved. So it was not the small access cavity was not able to flush the debris. So I want to emphasize that it's not only something related to the fracture resistance of the tooth. It is something very important related to the stages, different stages. And also staying on the same area in the anterior teeth. A lot of cases that I'm retreating in the anterior area, we can find a lot of discoloration. This is very big problem. If any one of us wants to make conservative, I'm not speaking about ultra conservative, maybe conservative, maybe contracted access cavity on the anterior teeth, he didn't want to remove too much tooth structure, he has to work under magnification, he has to have ultrasonic tips, and to be sure that he is cleaning all the the bulb tissue from the bulb horns. Otherwise, please, if you don't have all these equipments, please go with the traditional access cavity and de-roofing everything in order to follow the principles. And of course, removing all the caries, because we don't want Streptococcus mutanus and any lactobacilli to enter into the root canal and to increase the bacterial and the problem of the root canal treatment.
Thank you very much, Talal.
My idea about the subject.
Fantastic idea. Thank you. Emmanuel, what do you think? If we don't have microscope and ultrasonic tip, as Talal said, we shouldn't cut small access cavities, or what do you think? What is your idea about that?
Completely agree. In fact, even with microscope tips, I do not perform the conservative access cavity. It's important to understand, and Dr. Talal has emphasized this here. The conservative access cavity, it indicates that you should and you need to preserve the pulp horns or the roof of the pulp chamber. And I don't agree with this idea. So you can be small, but without preserving this roof. What I do is do a kind of conservative or traditional access cavity, and preparing with ultrasonic tips the roofing of the pulp chamber. So I have convergent walls, but without any roof in the pulp chamber.
Thank you. Thank you. Talal, anything else do you want to add?
Yes, if you allow me.
Yes, please.
The idea between being conservative or being traditional, I think it's or must focus on very important issue. If we go with the traditional, we know that all the dentists, they open the access cavity using the high speed. So they try to draw the access cavity according to their imagination, how they been taught in the university. So by this, they are sometimes, and most of the time actually, when I can see this in retreatment cases, they are removing from the pericervical dentine. Emphasizing on the conservative access cavity does not mean that you need to preserve unsupported dentine and preserve something that will hide bacteria beneath, but on the other hand, to learn how to use the ultrasonic in order not to touch the pericervical dentine, threatening the fracture or horizontal fracture resistant of the tooth.
Thank you. Thank you very much. Arvin, please carry on.
Thank you very much from everyone. In the at the rest of the article, we discuss about the conservative access cavity. I discuss about this. The next one that I don't know why it doesn't go to the next one. Yes. Is ultra conservative access cavity on anterior teeth. As we know, it has less extension as it's seen in the picture. It has less extension. The difference between the right and left picture is that in some conditions, such as when we have attrition or we have deep concavity in lingual aspect of the tooth, we can, in this type of access cavity preparation, we can extend the access cavity into the incisal edge parallel to the long axis of the tooth, and it becomes the shape that we've seen in the right picture here. That's because of these two conditions. We can prepare our access cavity like this. The next one is caries driven. It's same as the posterior teeth, just remove the caries, and also the restorative driven access cavity is same as posterior teeth, just remove composite that's been used to restore the teeth. After discussing about the nomenclature, we are going to see what was the influence of these types of access cavities, minimally invasive or conservative access cavity preparation on our procedures.
Arvin, sorry, Arvin.
Yes,
Arvin,
yes, you're welcome.
Just wait. Emmanuel, please go ahead.
Just a small speak here. This classification it's not only a clinical classification, but it's very important for research purpose, because we have a lot of groups performing studies with minimally invasive access cavity, and we observed that there was no consensual in the classification of these cavities. For example, some studies reported that ninja access cavity was a conservative access cavity. So for research, we believe that was and is important to have a universal classification, especially to compare the results between the different research groups. Just this observation.
Definitely. Thank you very much for this, because if you look at the literature nowadays, also there is some sort of idea that Professor Dummer and a very big group, we tried actually to standardize the way of the writing of each type of endodontic article in the future. And when we look at the clinical articles, we can see that now somehow they are standardized them by following the clinical trial rules. And maybe after 10 years, when we want to do a systematic review, it is very easy to do that because we have all the information which is necessary. But when people say something, but they don't believe in something else, and we don't have enough definition for that, definitely we need a classification. And thanks to Emmanuel Silva and his very great team. Now we have an access to some sort of standardization for how to communicate with each other. When we say small access, what does it mean? When we say ninja access, what does it mean? When we say ultra conservative, what does it mean? So this article can help us for that purpose. Thank you very much, Emmanuel. Is there anything else that you want to add? Okay, no. Arvin, carry on.
Thanks a lot, and my apology to Professor Silva, I didn't see you. Okay, in the rest of the article, we are going to discuss about impact of these types on our procedure. Different topics we are going to speak. First of all is about finding the exact location of orifices. The next one is our mechanical canal preparation to see how these access cavities impact or influence these procedure, and our root canal filling and retreatment. First, we start with orifice location. The results has found that detection of the exact location of orifices was not influenced by the different types of access cavity, traditional or conservative. If we had these three equipments, we have these three conditions in our practice. First of all was magnification and using dental microscopes. Second one is about having enough illumination at the site that we work. And the third one was using the ultrasonic in our procedures. So if we had this equipment, we have these conditions, there is no difference between traditional and conservative access cavities in finding orifice locations. But the detection of extra canals has been impaired by using ultra access cavity. So it's a drawback for this kind of access cavity. But about if the knowledge of the operator, the dentist that's doing this procedure in the study, does it impact on finding the canals? It's very important factor, but its impact is not being clearly shown, and it needs further studies to came to a result to find it if it's important or not. But potentially it's a confounding factor that it should be investigated in the future studies.
Arvin,
okay.
Sorry to interrupt you again. I want to ask a question about the use of CBCT, because we mentioned actually the use of ultrasonic and use of microscope. Emmanuel, what about having a CBCT prior to initiation of a root canal treatment if we want actually to have a conservative access cavity? Is there any special suggestion for that purpose?
Yeah, that's a perfect question, because all the studies included in this review, the endodontist was blinded to the number of the canals. So people do not have access to the CBCT image or to the micro CT image. So it might be possible that having the CBCT image, you can detect all the canals, even in the ultra conservative access cavity. But we do not know that if you know that you have the 4 canals or the 5 canals, you can form a ultra conservative access cavity and locate these canals. We need studies to confirm this. We need studies because usually when you have a CBCT exam and you know that you have a MB2 canal, you perform a additional extension in the access cavity. So we do not know that. Knowing the presence of the extra canal or the MB2, for example, canal, you can perform ninja access and locate. So we need further studies even calculating the percentage of dentin removal and these issues.
Yeah, and also it comes to my mind about the guided endodontic access cavity preparation, because we know that there is a trend in endodontics, especially in American Association of Endodontics, to work on this guided endodontic treatment. Obviously, they need a CBCT before this guided endodontic treatment. And during this guided endodontic treatment, they cut a very, very small access cavity. And they have CBCT. What do you think about that? Should we add that one to one of the positive way of small access cavities or not?
Yes, it's a possibility, but have you ever I performed some guided endodontics.
I didn't.
Yeah, I have performed 1 or 2 times, and the burrs are like 1.2 millimeter burrs. So you destroy completely the pericervical dentin. So it makes no sense to me. You are removing less in the access cavity, and you are removing more than the necessary in the entrance of the root canals. I do not know. Moreover, in US, I think it's easy to have a CBCT exam. All the patients can have this exam, but here, for example, in Brazil, it's not all endodontists that can perform a CBCT to all the patients. So we have to think about the epidemiologic endodontics too, because it's okay to me to work with high technology, and I have a microscope, I have access to CBCT, but there are a lot of endodontists that do not have these technologies. So these people cannot do endodontics. It's not the right way to think, thinking about epidemiological endodontics.
Okay, thank you very much. Is there any comment, any question from our participants? Anything? Yeah, I can see Viresh wants to speak. Viresh, please go ahead.
Hi, sir. Sorry, I'm in between my tennis game, but I was listening to this discussion. So I was of an idea that CBCT advice, to give an advice for CBCT is really nice. But for every case, I would not call it as a use of CBCT. Probably I would call it as an abuse of CBCT. Right? Means CBCT is probably meant for, advanced cases where we really feel that we are stuck and we need a guidance. That is my take on it. But in case, because there are a lot of limiting factors to use of CBCT, that one is like just now the author said that availability of CBCT. One. Second is if we are already using magnification and we can see what we are doing with minimally invasive instruments, then do we really need the use of CBCT before starting in just for excess cavity preparation? That is my actual question.
Okay, Emmanuel.
Yeah, it's a good question. I don't know if I understand completely, but you are.
I think Viresh wants to emphasize on the overuse of CBCT, because maybe actually this question was from me, because I suggest the use of CBCT when we want to cut a very conservative access cavity, obviously, or guided endodontic treatment. Obviously, if it is a very straightforward case, not a challenging case, nobody is going to suggest the use of CBCT or guided endodontic treatment. Speaking about this type of challenging endodontic treatment is about the small calcified chambers, a small calcified root canal system, that we need this guided endodontic treatment. So therefore we need to have CBCT prior to that. I do agree with you that unfortunately CBCT is overused sometimes, and it shouldn't be overused. But if a dentist decide to do some sort of conservative access cavity without CBCT, there is a danger of overlooking root canals, which is very, very dangerous in terms of outcome. And as Emmanuel said, we need further studies for that purpose. I do agree with you, Viresh, and I'm not emphasizing on the everyday use of CBCT, obviously. However, CBCT is going to give us a lot of information.
Right, right. I agree. Thank you, sir. Thank you so much.
Okay, Merich, please go ahead and give us your comments.
Yes, I agree in some aspects. I have performed already a few guided endodontics. In the current situation, it is not useful because we need thinner drills, as Arvind said, and we need more sensitive CBCTs to be more accurate. It is not enough yet, but I really believe that it is a way worth to invest in, because we cannot develop it without trying, right? I suggest to keep trying, and the technology will help us with finer CBCTs and with finer drills. And the team, with this technology, I believe that minimally invasive endodontics can be more possible because the team, the dental team, once getting the CBCT, the dental team can make more accurate preparations before the very first session. You can choose the correct rotary instruments. You can even order from the dental store the correct drills and everything, like implants. So that the quicker endodontics in the single visits can be more possible with this technology. However, in the current circumstances, it is not enough sensitive yet.
Okay, thank you. Kavita, please go ahead and give us your comment.
Thank you, Dr. Nikufor. My point was with this with the anteriors, the incisal-driven access cavity preparations. There's a study by Rajesh Krishnan which says that the instrument efficacy is better. So we did a similar micro CT study at our institute, which showed that the instrument efficacy was better when it was an incisal-driven access cavity preparation, and also the fracture resistance was less, although it was a repairable fracture as compared to that of the conventional access cavity preparation for the maxillary anteriors. So I would really want to know what Emmanuel would say about this.
Emmanuel, please go ahead.
Okay, so we have a lot of studies regarding the fracture resistance, and we have strong limitations in some studies. Even in our studies, we have strong limitations, and we are trying to improve our method. But we will discuss it further, the fracture resistance. But nowadays, what we have of the results is that we have a lot of conflicting results. Some studies showing better fracture resistance when you perform a conservative access cavity, but most of these studies shows no difference between the different access cavities regarding the fracture resistance. Of course, I understand that some studies that showed improved fracture resistance, but most of them did not show these results. So I think we need to study more and more and more until the moment that we have a definitive conclusion or a better conclusion regarding the fracture resistance. What I also believe is that the main problem in endodontics, at least in the endodontic literature, what we seen regarding the failure of root canal treated teeth is not the vertical root fractures. It's mainly due to endodontic problems related to low disinfection or persistent pathology. So I think it's more important that we discuss some issues like root canal preparation in conservative access cavity, or even the possibility to perform a good disinfection in those minimally invasive access cavity, then only evaluating the fracture resistance. You understand my point?
Yes, but with the incisors, I'm talking exclusively with the maxillary teeth, wherein we researched with the incisal-driven access cavity preparation. The amount of the untouched dentine wall was very, very less as compared to that of the conventional access cavity preparation. That itself says that the instrumentation efficacy was better when it was a straight line incisor-driven access cavity preparation. And it was a micro-CT study, we just published it. Okay, so even instrumentation efficacy was better when it was a conservative access, which was incisor-driven for the anteriors. So,
yes, I do not remember this study, but well, it's published. But we need to read better the studies, especially regarding the sample selection, because a lot of times we do not have a pair-matched samples. And this is a big problem in the study designs, because sometimes you can be comparing oranges with apples, and you have the different results because you do not have a fair comparison. I'm not talking that this study do not have a good sample selection. No, I do not remember this study. But this is a big issue that we should evaluate. Okay, if you have a straight line access cavity, you maybe can touch more walls, especially in the coronal portion. You can touch more walls. But we also need to understand which type of conservative access cavity was performed in this study, because the simple fact that you performed an access cavity in the incisal does not means that you are doing a conservative access cavity, because if you unroof completely the pulp chamber, you do not have more conservative access cavity, even when performing it in the incisal. Okay?
Yeah, thank you very much. That's a very good discussion. Thanks, Kavita and Emmanuel again. Emmanuel, I have another question about the way of evaluating the outcome, because in any of this outcome measurement, we didn't mention anything about, for example, post-operative pain or long-term success. We're just speaking about the fracture in the laboratory level, or we're just speaking about the removal of bacteria when we introduce bacteria in the laboratory level, and then we just remove them and we follow some indexes that we put on the bacteria. And the important thing is we need to look at the real outcome, which is the clinical outcome. And obviously, I don't remember any study to show about the clinical outcome. Please give us some idea about that as well.
There are no study, no clinical study published yet, and in fact, we have write an editorial to the International Endodontic Journal, making a call for studies, because we need those clinical studies, especially the outcome studies, the success and failure studies, but also pen studies, also disinfection, but in a clinical scenario. They are important in this moment, and to have more conclusions regarding such type of cavities. Even I understand that it will be difficult to have a prospective study, to have a randomized clinical trial of success. This is a difficult design study, but even a retrospective study, a serious retrospective study showing the outcomes of such type of access cavity would be important in this moment to endodontics.
Yeah, so designing such a clinical trial is almost impossible, I would say, because as you said, we cannot compare orange with apple, and we need to somehow compare them when we want to have a clinical trial. We need two groups with exactly similar situation of the teeth, which are almost impossible to have such a group. There are some two comments that I have received in the chat room about the use of the photodynamic therapy and laser therapy inside the root canal system to get rid of the bacteria when we have a small access cavity. What do you think about that? And I'm going to ask this question from Professor Talal as well. What do you think about the photodynamic and laser therapy when we are going to use a very small access cavity? Also, there is a comment about the gentle wave as well, the gentle wave system and use of gentle wave to preserve the coronal part of the access cavity and coronal part of the tooth. Please, Emmanuel.
First of all, I will answer the gentle wave question. I do not have experience with gentle wave, but of course I have read a lot. And as far as I know, you need to perform a traditional access cavity when using the gentle wave, because you need to attach the system in the tooth, and to this you need a conventional access cavity. So I think it's not possible to use the gentle wave with a conservative access cavity. It would be a nice idea to those that perform conservative access cavity, but I do not think it's possible clinically. Regarding the photodynamic therapy, I also do not have a lot of experience. We have been studying this in laboratory setups, but I do not use photodynamic therapy clinically. But I think if it can remove more microorganisms, if it will improve your disinfection, it's okay. I do not see any problem to use such type of technology. But again, we need to study this or study the photodynamic therapy use in the conservative access cavity before doing this clinically and stating that, oh, I perform a conservative access cavity, but I use photodynamic therapy, because we don't know if it's the equilibrium of disinfection and conserving the dentin. If it's possible to achieve a good disinfection just using the photodynamic therapy.
Okay, and what about the use of EndoWAC?
Again, it's the same of the photodynamic therapy. I think it will improve the disinfection of the endodontic therapy, but we need to study if this disinfection will be adequate or not. If the access cavity will not be impairing the disinfection with the EndoWAC device.
Okay, thank you. Talal, please go ahead and give us your idea about all this question. Talal, are you in? Okay,
thank
please.
you. Yes.
Photodynamic therapy, photodynamic therapy, and all others, please. EndoWAC.
Okay, I do believe, regardless of the way, if it's photodynamic or negative irrigation or whatever, we have to emphasize about two issues. We need, during our irrigation, in order to improve the outcome, for both active irrigation and irrigation activation. For active irrigation, we need to see the debris coming out. If we have very small access cavity, this will prevent, at the end, if I'm doing some photodynamic activation, I don't need dead bodies of bacteria inside the root canal. I need them to go out. I need them to be flushed from the root canal. So it's very important to have good space, not only for negotiation, but also for the debris to come out, for the flushing. And then after that, after good cleaning, I need to do an activation. So this is the idea. If I have very limited access, we go back to the sample, the example that I mentioned, the case that I treated last week. It is a problem that a very big, huge pieces of organic tissue were coming out. The dentist was treating for a long time, but he still keep this huge amount of bacteria inside the root canal. We don't need them. So I need at least a space for me to flush the canal, to do active irrigation. I do apply some ultrasonic tips. They are very soft, and I open the water, the saline, so I will be able to clean. If I don't have space, I will not be able to clean. Then I do my sodium hypochlorite and then activation. So regardless of the way it's photodynamic activation or the gentle wave, I don't have experience actually with gentle wave, but I want photodynamic, I want to activate. How come I activate and I still have debris? I need to remove, then I have clean, and this is my take on this point.
Thank you very much. Emmanuel, do you want to add something to what Talal mentioned? And I'm also asking Hessam, because Hessam sent us a comment about the CBCT, if he can also give us some information, because I know Hessam has got a lot of cases using different types of access cavity as well. Okay, Emmanuel.
Dr. Talal, perfect considerations, and I completely agree with you. And I think that one of the problems with the conservative access cavities is that we cannot penetrate with our syringe inside the root canals in an adequate way. And also we do not have an internal flush in the root canals, okay, to remove the debris completely and even to have a good flow of the irrigating agents inside the root canal. This should be also evaluated. I do not have the know-how to do this here, but I'm pretty sure that there are some groups in the endodontic world that can do this, evaluating the flow of the irrigating solution inside a root canal. And I'm pretty sure that it will be different when you have a conservative access cavity when compared to a traditional access cavity. I think the flow will be worse in the conservative access cavity. It's my opinion. It's not scientific.
That's great. Thank you very much. This is a very informative discussion. Thank you very much. And also a good thing that I want to say is because in this group that we are discussing now, there are a lot of postgraduate students from around the world. When we speak about the possibility of the future studies, that means these postgraduate students can contact their professors, then they work together. Obviously, I'm sure people like Emmanuel Silva, like Talal Al-Nahlawi, and many of us here are ready to accept the proposal and work with different groups as an international publication. That would be a very good idea to work together under the umbrella of 1 or 2 or 3 universities all together. So one of the reasons of this type of discussion is to propose future studies for young fellows that they are with us now. And I'm 100% sure that people like Emmanuel are more than happy to help for any of this type of topics that he suggested. Hessam, can you speak please for us? Hessam, can you turn on your microphone and give us your idea?
Hi everybody. Do you hear me?
Yes. Can you turn on your video as well?
I think it's on. Or not?
Oh, yes. Now we can see you. Thank you very much.
Okay.
Please go ahead.
Hi to everybody.
Hessam, please introduce yourself to the team and then go ahead.
I'm Hessam. So what? I'm Hessam. I graduated at ACTA in Amsterdam. And at the moment, I'm working at the Department of Endodontics at ACTA, also Department of Dental Materials. First of all, I want to thank you, Dr. Nekoufar, for all of your efforts. It's really nice. I'm really following every time, and it's getting better and better. And also happy Nowruz to all to those who celebrate it. About the topic, there was a time for my ego. I also did lots of these fancy access cavities, but then later it came to me that actually also regarding to the strength of tooth, because as you know, I'm graduate. I did my PhD in dental material, so about physics and mechanics and these things, I think it even for the strength, the effect is not that much to perform this type of access cavities. So I totally agree with Emmanuel that we need a maybe it's kind of conservative traditional access cavities. So we need to enroof the pulp, and I totally agree with Emmanuel.
Okay, thank you, Rash. And you mentioned something about the CBCT in your comment.
About the CBCT, I think considering ALARA, I'm not sure if we can make CBCT for all of cases which need endo treatment. I mean, yeah, maybe it's ethic problem to make CBCT for all of cases at the clinic. But yeah, I know that there are clinics that they make just as routine. It's the routine procedure. So they make CBCT before the root canal treatment and after the root canal treatment. Yeah, but at least in the Netherlands, we cannot do that.
You cannot do that.
It's it's difficult. I mean, considering the ALARA, it's difficult to justify that.
Okay, thank you very much, Hassam, and thanks for your cooperation with us. And please carry on joining us our online journal club. Okay, Arvin, please share your presentation and carry on, especially because of the time. I'm a bit worried to finish at 90 minutes that I promised. Okay, carry on.
Thanks, everybody. If we want to carry on, we had reached here. Yes, we were discussing about chemomechanical canal preparation and the effect of different kinds of access cavity on it. So as it's found in this review, there were no difference between traditional access cavity and conservative access cavities when we compare untouched canal walls and accumulated hard tissue debris remaining after preparation. This accumulated hard tissue debris has an abbreviation called AHTD, that stands for this, and it's been shown no difference regarding these two issue, but we have greater canal transportation when we use conservative access cavities. And also the irrigation has been impaired when we use truss access cavity and ultra conservative access cavity or ninja access. So these two access cavity had a negative effect on our irrigation efficacy. About the bacterial reduction, this review couldn't find the clear results about this, and so they concluded that it's unclear regarding bacterial reduction. So the further studies it's been needed here in this area to come to a conclusive results. Speaking about root canal filling and retreatment, it's been also found that maybe there is influence, there is a relationship between cross-section of a canal shape and the outcome of the filling procedure. So as we know, it could be important, but it's clear that we have difficulties in removing our filling materials such as guttaperca from the pulp chamber when we use minimally invasive access cavities. So it may be complicate our removal of guttaperca. So our retreatment procedure may take longer time when we use conservative access cavity. It's been mentioned in this review, and as we know, the time of our appointment is very important because the patients that come to us, we visit them. It's very important for them to finish the procedure in less time. So it's been shown and it's been found that in the presence of conservative access cavities, the time became more and longer. But about the difficulties, it's been shown that maybe when we use some instruments that have asymmetric cutting motions, it would be more effective and it may make our problems and difficulties less when we use these instruments. So about this, after discussing about these three procedural difficulties and their influence of access cavities on them, we are going to discuss about the more important, in my opinion, thing that we see whether these types of access cavity influence on the fracture resistance of the teeth or not, because all of the things that we are going to do and all of the complications that we are going to suffer is because to enhance the fracture resistance of the tooth, as we've seen here in these studies. Between the 14 studies, 9 studies found no statistically significant difference between these different access cavity preparations. So there is no scientific evidence that shows a real benefit when we use conservative access cavity to enhance our tooth's fracture resistance. Besides the results that been found, the review mentions some methodological drawbacks. That's the first one is about aging. As all of us know, aging may negatively impact on the tooth toughness, and as the tooths grow older, the fracture resistance and the resistance to being fractured decreases, and the tooth became more susceptible to fracture. And this is the most neglected factor that it's neglected in published studies. So it may be very important to consider this factor in our studies. The next one,
sorry, Arvin, can I stop you?
Here? Yes.
Arvin,
yes,
can you go back to the previous slide, please? Emmanuel, I need more description about the effect of aging.
Yes, this is a good point.
And sorry to interrupt. When we are speaking about the age, are you speaking about the age that we calculate easily to say how old are you, or the age of tooth depends on the trauma, depends on the masticatory forces, depends on the occlusion and others?
This is a perfect point, because it's real difficult.
My points always are perfect, Emmanuel.
Yes,
don't worry.
Yes. You know, it's very difficult to know the history of the tooth. When we receive the tooth in our lab, we do not know if this patient has any masticatory habit, if what is the antagonist of the tooth, the age of the patients, and the habits of these patients. So it's difficult to know the real influence of these points in the fracture resistance of the sample. So what we are trying to do now, but it's really difficult, is to have tooth from the same patient and with the same conditions and contralateral teeth, and try to perform the different access cavity in those contralateral teeth, considering that the patient has the same antagonist within this tooth. But it's really difficult. We are trying, of course, we are in the middle of a pandemic here in Brazil and in the entire world. But we are trying to have these samples, and in 6 months, we have only 4 teeth. So it's really, really difficult to have such type of samples. And we do not know what's the influence that these issues have on the fracture resistance of the tooth. So we have to consider this as a risk factor, because it's a real
what
problem.
about increasing the sample size? When we do such studies, if we increase the number of teeth, can somehow we solve this problem or not?
Yes, but as we do not know the influence, we do not have any study evaluating the fracture resistance in these different situations. It's difficult to perform a sample size calculation, an adequate sample size calculation to remove this bias from the results. So we need to solve this problem, but I do not believe that it will be solved in the next years, because it's really difficult to have such type of sample.
Okay, thank you very much, Arvin. Please go ahead. We just have 15 minutes, even less.
Okay, thanks a lot. The other drawback that's been mentioned in this review was the thing that were discussed previously, the lack of three-dimensional imaging, and lack of, we don't know the exact anatomical shapes, but it's been mentioned that despite all of the efforts that all of the studies that's been reviewed here tried to match their teeth, but we know that it could not be exactly matched. So there is lack of anatomical matching here that impairs the validity of each studies. And as it's mentioned, the only tool that we have is CBCT or micro-CTs here that maybe is not very, very exactly precise. The other drawback that's been mentioned here is that we could not simulate the exact condition that exists in our mouth, because as you know, lots of forces, recycling and mechanical forces are present in our mouth that in our experiments we could not simulate all of them. And it's been shown that without this simulation, the fracture resistance of teeth with traditional and truss effects was exactly similar to control teeth. But when we expose our samples to thermocycling, the condition became different, and the teeth with traditional access cavity had the least fracture resistant strengths. And also about the cavity preparation and restoration, it's very important that we know that the difference between the real situations and our experiments is that when we restore one tooth after RCT, it has better fracture resistance, but here, no. Professor Silva, yes, you're welcome.
You can return to the last slide.
Yes, of course.
Thank you.
Here.
One way to remove the bias that we are talking and discussing before is to simulate the oral masticatory function and aging, because in this way we can have a more standardized sample. It will not be the best way, but it's a way to remove partially this bias. And in fact, I have a good news now, because we have the first study accepted on the International Endodontic Journal today, that we use this simulation of oral masticatory function and aging with thermocycling. And I can anticipate the results. We have no difference in the two different types of access cavity. So even with the simulation, the conservative access cavity did not perform better than the traditional access cavity. So just a point that I think it's important to discuss here.
Thank you very much, Amanda. Arvin?
Yes, thanks a lot. As I was
you need
mentioning,
to finish in 5 minutes. Arvin.
Yes. I talked about restoration, but if we came to a conclusion that we want to conclude from all of the review, when we consider our scientific data, there is also lack of strong evidence to support this claim that these minimal invasive access cavities can preserve fracture resistance in the teeth that we treat. compared to traditional access preparation. This was the first conclusion that we can conclude from this review. The other one was that performing conservative access cavity maybe would, it seems that it doesn't affect our clinical procedures when we compare different stages of our procedure. But a very important point is that we need to conduct these types of access cavity in the in such settings that we have perfect illumination, magnification, and other conditions that facilitate our procedures. And the other conclusion that we find is that maybe the more conservative types of access cavity, such as truss access cavity and ultra conservative access cavity, may negatively affect our procedures and make more canal transportations and complicate our irrigation procedures. So they are not recommended in the teeth, especially when we have necrotic pulp, because it's damage and its complications may be more. And finally, it can be concluded from this review that there is little evidence, and we have lack of evidence to support the introduction of these kind of minimally invasive access cavity preparation into our routine clinical procedure practices and procedures, and train our student both undergraduate and postgraduate based on these types of access cavity. Thanks a lot. This was
Thank you very much, Arvin. You did a great job.
Or maybe,
great.
Yes, thanks. This was my second or maybe third international presentation, and I'm very honored to have this presentation and learn a lot from all of the professors and authors. Thanks a lot.
Thank you very much. You are the best. Thank you. Please unshare your PowerPoint.
Okay.
First of all, Emmanuel, yes. Professor Ibrahim, and all of the professors around, Marich, Talal, everybody, Essam, all of you, I cannot mention all the names. We are going to give mark to Arvin because this is a part of the credit that he will get from the course in the university. So, Emmanuel, you can be the first because you are the first author. What degree or what unit can we offer to Arvin for his presentation? A plus, B plus, C or D or whatever?
The highest level, A plus. I don't know what's the highest level, but I was impressed with the presentation, and it was really good.
Okay, thank you very much. Others, Professor Ibrahim, you are the mature one. You are the mature one. Turn on your microphone, please.
I want to get not to forget to give me just to summarize and sum up all this discussion.
Yeah, just I give you that. You're always the last one. Not now. Just give the mark to Arvin.
I will second Dr. Silva's opinion, because really he did a great job. He did his homework very well, especially under your strict, guidance.
Okay, I need the third one. Talal, you go ahead about Arvin.
A plus for sure.
Okay, thank you very much, Arvin. Thank you very much.
Thanks a lot.
Thanks a lot. Okay, Arvin, I'm very proud of you. Thank you very much. And then it's time to say my highest appreciation to Emmanuel Silva. I know this is the time that Emmanuel is working. This is almost 11 o'clock or 12 o'clock in Brazil, Rio de Janeiro. And I know he's working in the clinic, in the department, and he kindly share his valuable time with us. And I'm sure this is a very good start for our future collaboration in Asian Pacific Endodontic Confederation and in our university and your universities with him and his team. And I know he is very young and he has got a lot in front of him. So we are looking forward to have his collaboration with all of us in the future. And believe me, when I send my first email to Emmanuel, that was just like 5 minutes after that he kindly replied and accept my invitation. Thank you very much, Emmanuel. What am I going to ask? I'm going to ask everybody to turn on their videos and turn on their microphones and then put their hands together for Emmanuel Silva for his valuable sharing, his valuable time and publication, amazing publication. Thank you very much, Emmanuel.
Thank you.
Thank you. Thank you so much.
Emmanuel, please go ahead, give us some comment, and then usually what we do at the end of the session, we ask Professor Ibrahim Abu Tahun to give us the conclusion of the session. Emmanuel, please, last word.
Perfect. Just want to thank you for the invitation. It was a pleasure to stay here with you. And I'm open. If you need any other discussions, you can contact me on the email. I'm pretty sure that I can answer your questions, and I'm really thankful for this time here. Thank you so much.
Thank you very much, Emmanuel. Another thing is we always promise to be very punctual. As you know, we start at 13 GMT, and now we just finished at 90 minutes. So we have 3 minutes, 2 minutes for Professor Ibrahim, and 1 minute for me. Ibrahim, please go ahead.
Yeah. Thank you very much. Thank you for this informative lecture, Dr. Emmanuel. And really, I'm happy you were relaxed and comfortable on the hot chair of Dr. Nikufar. Usually, I know how much stress it creates to all the authors. Anyhow, today passed easily and smoothly, thank God. What I want to say is that to start from the end, I would say that the radicular preparation is the continuity of the access cavity preparation. The fact is that let's say the concept of total endodontic preparation refers to both coronal and radicular preparation, each prepared and completed separately, but ultimately or eventually flowing together into a single continuous tapered preparation from crown to apex. This is my first, and this ultimately should revert us back to the basic principles of access cavity preparation established by Dr. Black. This is a long discussion. What I want to say is that whether this is micro or macro access, whether this is traditional or maybe something else, what I believe in is what I call only complete access. What I mean by that is that what's meant by conservative access is access through natural tooth structures, but not through leaky old fillings. So in essence, when we do access cavity, we take what the tooth gives us. And this is very important. This is one. So I believe that personally, I do the access that will allow me or make me do good irrigation, shaping, and also good cleaning, shaping, and will allow me also good obturation, and should allow me to see the canals clearly. And this is very important. So we not need to be a curious octopus that goes off in all directions when we do access cavity preparation. But at the same time, we need a stress-free, well-oriented, well-refined access, especially to the complex anatomy and posteriority. And to end up this discussion, I would say that access cavity is a qualitative and quantitative experience and fashion. And what I believe in is that this is a matter of feel. And we are not going to proceed until this access, as I've mentioned, is complete. Thank you again, Dr. Silva. You did a great discussion today with us. I want also to thank Dr. Mohammed, and through him, Tehran University of Science, of Medical Sciences. Another great session, and hopefully next month, Dr. Mohammed, we will also have a great discussion. Thank you very much all.
Thank you very much, Professor Ibrahim. And this is the end of the session. And thanks again from everybody, from Emmanuel Silva, Professor Emmanuel Silva from Brazil, Professor Talal with his very, very interesting and informative comments, and all of you. And also Arvin Rezai for his collaboration and contribution to this great work. So we are going to have next month at same time, the last Friday of the month at same time, 13 GMT, our next sessions, and I will inform you by sending the banner and posters to all of you. And we are going to end up this session by a Persian music, because of the Nowruz, and to give you a very happy time and wish you all of the See you soon in next month. Thank you very much, and have a very nice evening. Goodbye, everybody.
Goodbye. Thank you all. Thank you all. Nice meeting you. Bye, Dr. Elki. Bye.
Bye. Thank you.
Thank you so much.
Bye.